my great pleasure as Clinical Director of Healthcare Variation at the Commission to welcome you to the 5th webinar in our series, Better Care Everywhere. In the spirit of reconciliation, the Australian Commission on Safety and Quality in Healthcare acknowledges the traditional custodians of country across Australia and pays our respects to elders, past and present, and extends that respect to all Aboriginal people and Torres Strait Islanders. Thank you for joining this live broadcast. The National Safety and Quality Health Services User Guide about clinical variation is your roadmap to identify, investigate and address unwarranted variation. There are real case studies which will help you guide you through the 6 steps to drive change and deliver better care. In today's webinar, we've invited a range of speakers to step us through this process. We're going to hear a range of perspectives from the front line and from administrative levels running big hospitals. So we're going to get, I hope, something for all of you. But before I introduce our speakers, can I do a bit of housekeeping? At the top of your screen, you'll see a number of bars. The purple is for participants to post questions and comments. And I've asked our speakers, when they're not speaking, to answer some of those questions. And we'll also have time afterwards to address those questions more fully. The green bar is to refresh. If we've got a notice or information for you, that'll be provided on the orange bar. And if you're unfortunately called away, then the red cross is the way to exit the session. If you do experience problems, do ring Redback on 1800 733 416. Let me introduce our speakers. Our first speaker is Professor Erwin Lowe. Erwin is going to talk about variation in clinical practice, reducing unwarranted variation, but increasing innovation, a really interesting concept. Professor Lowe is the Chief Medical Officer and Group General Manager for Clinical Governance for St Vincent's Health Australia. Our second speaker is Ms. Nicole Rasmussen, and who's going to talk about practical guide to identifying and addressing unwarranted clinical variation using her experience as Director of Patient Safety and Quality Improvement at Alfred Health. Nicole has a background in occupational health. Our third speakers are a duo, a lovely example of big picture and coalface change. It's called a case study in driving change, the Australian Stroke Clinical Registry. And we have Professor Dominique Cadilhac, who is the head of the Transnational Public Health and Evaluation Research Division, Stroke and Ageing Research at Monash University, Victoria, and Nicole Hall, who is the Stroke Clinical Nurse Consultant at Logan Hospital, Queensland, and the Hospital Coordinator for the Australian Stroke Clinical Registry. Not last, but by no means least, is Professor Jacqueline Close. She's going to talk about the Australian and New Zealand Hip Fracture Registry, and the title of her talk is Enhancing Outcomes for Older People. Professor Close is a geriatrician at the Prince of Wales Hospital, Sydney, and she's the Clinical Director of the Falls, Balance and Injury Research Centre at Neuroscience Research Australia. Now, before I hand over to the first speaker, can I remind you this is a great opportunity to pick the brains of experts in the area of reducing unwarranted variation. So go to the purple bar, click on it and ask any question you like or make any comment, and we'll try to ensure that all your questions are answered either during our session or subsequent to that. I hope you enjoy this session.
Hello, my name is Erwin Lowe, and I'm the Group Chief Medical Officer for St Vincent's Health Australia. I'm here to talk to you about variation in clinical practice. It's about reducing variation and increasing innovation in the health service. So we know that the literature tells us that improving quality and patient safety can be done by minimizing unnecessary variation. And this has been replicated through multiple research studies. We know that reports have been published on this topic, and the Australian Commission on Safety and Quality in Healthcare have released a guide for the review of clinical variation in healthcare, which is what actually this conference is all about. So how does a hospital network like St. Vincent's Health Australia monitor variation in order to address them? So there are a few ways. So the major way that most hospitals monitor data is through Kpi Tracking. That there's a key performance indicators, clinical indicators, and these tend to be automated, prospectively collected data, and it's useful. So things like medication errors, falls, pressure injuries are collected this way. This includes hospital-acquired infections as well. Then we can do audits as well, right? So audits are usually retrospective. They're more manual. It requires people with checklists to tick off, to ask questions or observe things. So we can do bedside audits, observational audits, or even paper record audits. But they're helpful, again, to identify variation. We can actually do deep dives too. So many hospitals identify high-risk areas and then do a deep dive investigation to ensure that there is no variation. And last but not least, there are clinical registries. There are different medical colleges and universities that collect registries for example, cardiothoracic surgery, emergency medicine, orthopedics. We know a good example of this in Victoria is the Victorian Audit of Surgical Mortality, or VASM. So these are central registries that collect data from different hospital units. They provide then back to the hospital report showing if there were any variation comparing the hospital with state or national peers. And they are useful as well. So I'm going to give you examples of how St. Vincent's Health Australia uses each of these methods to look at variation. So the first that we're going to look at is KPIs. So CLABSI, or central line associated bloodstream infections, is a very common clinical indicator that is monitored by hospitals. So for St. Vincent's, in 2018, we picked up a variation. We found, if you look at the graph, you can see, actually, you should see two lines, but you can only see one. And that's because St. Vincent's Hospital in Melbourne, the public hospital in Melbourne, had multiple instances of CLABSI infections in the ICU. St. Vincent's Hospital in Sydney, on the other hand, has not had a single CLABSI infection since 2017, and this record still holds. So what we did is we picked up the variation, and clearly then we needed to look into it. And the bottom is just to show you the breakdown between the different hospitals as part of the Melbourne and Sydney networks. So what we found was that there was variation in how people were using packs, how they were actually putting in the lines. And we came up with pathways and guidelines to reduce that and to fix that. We found out that people weren't washing their hands properly. They weren't following the 6 moments. In fact, the second moment was the issue. We picked that out through an audit. And so we provided training. And last but not least, there was very poor documentation in relation to putting in central lines. And we put in processes to fix that as well. And as you can see here, that was in 2018. You can see that in 2019, in fact, the Melbourne Public Hospital went back to 0. So we essentially fixed the problem. So this is how KPIs can help to minimize variation. The other thing that we do have in our repertoire of things that we can look at is audits. So we use what we call the MAS system, which is a database that we essentially manage at the group level nationally, but it's being used by our hospitals throughout the country. And an example that I'm going to share is standard for audits. So when it comes to audits, you can do bedside audits, you can do medical record audits, you can do observational audits. There are many different types. But with medication safety, you can see that we do a whole suite of audits on a regular basis. And I'm going to just highlight the one around the percentage of patients whose identity was checked before receiving medication. You can see that St. Vincent's as a whole nationally, we seem to do quite well, 89%. But if you break that down, this is a particular hospital and particular wards. You can see, actually, even though the consolidated number is 89%, you can see quite a bit of variation between the wards. In particular, the birthing suite at 50% and the maternity postnatal at 70%. So here, we picked up that the maternity wards in that particular facility had an issue with checking people's identity before they are prescribed or before they administered medications. So that's how we use audit. But then we at St. Vincent's implemented this deep dive program. So it's essentially a deep dive audit or review of high-risk areas. So we call it SCARP, or St. Vincent's Clinical Assurance and Reliability Program. And we looked at areas where we felt we should look at in terms of making sure there was no variation. So we looked at chest pain, acute coronary syndrome. We did it as a pilot initially over 12 weeks. And I'm just going to show you some of the data that we collected. So if we compare the Sydney Public Hospital with the Melbourne Public Hospital, again, because those are our two largest sites, and you can see in terms of demographics and people turning up, they were basically similar, about 50 people turning up a week compared to in Melbourne compared to 46 in Sydney. You can see then in terms of the rest of the demographics, we're going to detail the breakdown between female and male. They were all very, very similar where they were coming from. And then if you look at emergency presentations, again, quite similar, although interestingly enough, the presentations for chest pain peaked in Sydney on Monday, but peaked in Melbourne on Tuesday. And then also in Sydney, they had roughly twice the number of category 1s as well compared to Melbourne. Then if you then look at the time of presentation and how they presented, time of presentation was basically the same, but there were nearly half the patients in Sydney turned up with chest pain through public transport, while only 10% of that was in Melbourne. So interesting variation. What did we learn through this deep dive of chest pain? We found out that 100% of our patients received treatment within 12 hours, so that's fantastic. We found out that 83% of them had an ECG within 10 minutes, so not as great. And then 63% got door-to-balloon time. The door-to-balloon time for 63% was within 90 minutes, which is not best practice. So we kind of identified those issues. So what did we find, and then what did we do? So this is what we did. Through the findings, through looking at what we did, we found out that documentation in terms of what was going on was poor. So we provided training, beefed up our policies around that. We found out that there were different pathways being used, and we consolidated that at a national level. We found out that documentation of ECG changes was poor, so we fixed that as well. Risk stratification wasn't very good as well, so it wasn't poorly documented, and we provided training around it. And again, last but not least, the care plans that were being used was not documented properly, so we fixed that. One thing that we did find out of the deep dive was that the cath lab and the emergency department was siloed. They weren't talking to one another, and it was poor coordination. So we basically broke down the silos and got them together to come up with joint pathways to manage chest pain. The other thing that we did as a deep dive was stroke. And again, this is looking at variation to compare our hospitals with national and international data. So in terms of time-critical stroke, we know that nationally, 36% of patients reach hospital within 4.5 hours. The good news for us is that 100% of both our hospitals and our private hospitals as well got that timeline. Then we know that in terms of use of thrombolysis, 7% in 2015, 30% in 2017. We found out that Sydney was above the target, but Melbourne was kind of just below. And then in terms of ensuring the thrombolysis given in hospital within an hour, Australia actually as a country falls behind the US and the UK. In our hospitals, public hospitals in particular, we're actually above the Australian targets, so that was pleasing to find out. We know that 77% nationally of patients get care in a stroke unit. We found out actually that in Sydney, our public hospitals and our private hospitals get treatment in a stroke unit, but only half our patients in Melbourne got that. So that was a variation there. 35% of patients nationally did not receive a discharge plan. We found out that, in fact, and this is a reverse number, most of our patients did get a discharge plan, which was very pleasing for us to know. 33% are discharged without any prevention medication, but most of our patients did get that as well, which is, again, good for us to know. So what did we learn and what did we do? So we know that in Sydney, we did actually have a dedicated stroke unit in both our public and private hospitals, but this wasn't the case in our Melbourne Public Hospital. They had a stroke care team, but not a dedicated stroke unit. So what did we do? We created one in our Melbourne Public Hospital. We also found out that in our Melbourne Public Hospital, they did not have a cold stroke alert. We created that as well. So we got the Melbourne Hospital in line with our Sydney Hospital, and our results have improved since then. Now, the last thing that I want to touch on is registries. So I'm going to use the example of the VASM registry, the Victorian Audit of Surgical Mortality. We got a report recently, and we got a report, and because VASM is Victorian, I can only really look at our Victorian hospitals. So I look at the Melbourne Public Hospital and the Melbourne Private Hospital that St Vincent's run. And I'm not going to go into detail, but as you can see, in one sense, we can't really compare our public hospital with the private directly because our Melbourne Public Hospital is a tertiary academic hospital. Our private hospital in Melbourne is actually quite a small hospital, but we can actually compare them with the peers. So the good thing about the VASM report is that we get our peer state and national hospitals so that we can compare apples with apples. I'm not going to go into detail in terms of each of these, but you can see that there is some variation comparing ourselves with our peers. But here is a good example of how we can use this data. You can see that in terms of prophylaxis use against DVTs, our public hospital had an issue in the past couple of years, but they've fixed that. Similarly, in our private hospital, we had an issue as well, but that was identified through this registry data. Consulting in hospital is something that, as a group chief medical officer, I'm interested in. And as you can see, we got consultants in our tiers in both public and private, which is very pleasing to see. Unplanned admissions to ICU seems to be an issue in our private Melbourne hospital in the past few years. That was something that we need to look at. And then fluid balance. So this is interesting information. It's in the public hospital seemed to be, and in the private hospital seemed to have been an issue in the past. But again, emerging as an issue again in our public hospital in the past financial year. So what did we learn from this kind of registry data? One thing we learned is that we had an issue with our venous thromboprophylaxis guidelines and practice. So this is something that we identified and we dealt with. Fluid balance is the other issue that we identified. And again, both our public and private hospitals are looking into that. And then how we use critical care. What did we find out that we did well? Consultant in theatre looks as though we have that and we do that quite well. And it looks as actually from the VASM data that we actually identify our deteriorating patient early so that we have low complication rates as well. So as you can see, a hospital network like ours at St Vincent's, we can use KPIs, we can use audits, we can use deep dives and registry data to monitor for variation, identify issues, and then come up with recommendations to fix it, and then we can evaluate what we've done. The last thing I'm going to talk about really is the tension between reducing variation and increasing innovation, which is the title of my talk. So how do we do that, right? So on the one hand, innovation is about disruption. It's about making step change and creating a paradigm shift within your hospital. Whereas reducing variation actually is the opposite. It's about standardization. It's about telling people, follow guidelines, don't vary. Well, actually, if you look at the literature, they tell you that they go hand in hand. So innovation and reducing variation are two sides to the one coin. There is no question that reducing variation improves quality and safety and care because the literature tells you that. So that's the kind of new standard line that you can see on the graph in front of you. But innovation is when you come up with a new technique. So when research studies tell you this is the new drug that you need to use now because the old drug has been superseded, or this is a new practice because we have done research to show this is a new model of care, or through innovation, through an invention, someone has figured out this is a better way of doing something, then you make that the new standard. So then what happens is you tell everyone else, look, this is the new guideline, this is a new policy. Everyone now has to reduce variation to follow this new standard. So that's where the graph shows you that innovation goes up and then new standards. The Kaizen, this is the lean methodology, the lean terminology that people use. You want to reduce variation and then until the next innovation, and then you innovate and then you kind of reduce variation up to the new standard. Does that make sense? So hopefully you can understand that in fact they go hand in hand, and you do need to have both processes going on at the same time. So I'm going to stop here. I'm happy to take questions. Feel free to email me at any time, and thank you for listening.
Hi, my name's Nicole Rasmussen and I'm the Director of Patient Safety and Improvement at Alfred Health. Over the next little while, I'm going to take you on the hitchhiker's guide through the galaxy of clinical variation and also a practical approach to the identification and management of unwarranted variation. Before we begin, I would like to acknowledge the Boonwurrung clan of the Kulin Nation, who are the custodians of the land and waters on which I stand, and pay my respects to the elders past, present and emerging. In terms of where I'm coming to you today is from the Moss Room, which is the recently opened Innovation and Education Hub at the Alfred. So behind me you'll see a solid wall of green, and believe it or not, that's actually live moss, and this surrounds all of the walls of this room. The intention of this room is to promote thinking and conversations that are energised, expansive and elevated, and I thought that's quite fitting given the conversation that we're hopefully in the presentation that we're covering today. A little bit about Alfred Health. So we are a quaternary health service located in the inner Bayside suburbs of Melbourne, metropolitan Melbourne. We provide acute, subacute, community and specialist outpatient services, as well as I think a total of 17 statewide services, so essentially caring for all of Victorians. What this means is that at any one time we've got over 50% of our patients that are with us actually reside outside our immediate catchment area. We're a major provider of trauma service, and we have a sizable ICU of 44 beds that split over two levels, creating a surgical and a medical ICU service. So essentially, we care for some of the most complex and sickest patients within our state. And that context is particularly important as I'll step through one of the examples of clinical variation analysis and improvement that we've undertaken at Alfred Health. So why are we focused on clinical variation? Variation in practice in and of itself isn't bad as such when it's aligned with or in accordance with a patient's clinical care needs, or in accordance with a patient's preferences and healthcare choices. Variation that isn't aligned with these factors can lead to suboptimal patient outcomes, patient harm, and ineffective use of clinical resources, either through over-servicing or, importantly, under-servicing, where patients don't receive or have access to the care that would make a big difference to their quality of life. It's difficult, I think, in healthcare. We have finite resources, multiple priorities, competing priorities, and loads of data. So it's really difficult to identify where or how to begin. And this is where the user guide to review of clinical variation is important. It outlines some key priorities, key criteria that health services can use to inform their priority areas. I've listed just a few here that are most relevant to Alfred Health and that we routinely use to inform our identification of areas for priority focus and analysis. So the next step is identifying how to assess clinical variation. And the first part of this is actually looking to the data that's available. And in my mind, this forms into two broad categories. One is around a top-down approach, and the other is bottom-up, which I'll come to on the next slide. The top-down approach consists of benchmarked external data. Some examples are listed there, but I'll pay particular attention to clinical quality registries, as this has been an area of focus for us at Alfred Health over the last 3 to 4 years. The clinical quality registries are an important data set that provide oversight to the appropriateness and effectiveness of care delivery within a very specific domain. They provide opportunity for comparison against performance against our peers, and also provides an opportunity to identify outliers where they occur. Alfred Health participates in over 70 clinical registries, and 25 of these consist of benchmarkable data, and they've become a critical data set that we routinely review and use to inform our opportunities for improvement. Interesting, the clinical quality registries also align, some of them align to the clinical care standards. So it allows for a streamlined approach to the evaluation of the performance against those clinical care standards. So they're a critical information source for us around appropriateness, effectiveness of care. The other data set is bottom-up, or what I consider internally derived. So it's information and performance data around our quality and safety delivery, often at a patient level or unit level. It's learnings from serious adverse event reviews. It's the learnings or referrals that come from mortality and morbidity review meetings, and also, of course, the comparison of performance either across units, quality and safety across units within the health service, or aligned with those external KPIs and benchmark targets. So once you understand the data set that's available, you identify which data sets are appropriate for comparison in line with the priority area that's in focus. The next step is to undertake analysis. And the purpose of undertaking analysis is to identify where there is clinical variation, but importantly, understand where that variation is unwarranted and identification of opportunities for improvement. It's at this point that the data in and of itself will not provide the answer. It's important to engage the clinical workforce and the expertise that's within the health service to help understand and accurately triangulate the data to perform a picture around patient care and outcomes. Importantly, engagement of clinicians and the custodians of the data is important. We found that particularly the case with the clinical quality registries, because it's understanding the data definitions that sit behind that, the risk adjustment, if there is any, and so on. Equally important is to consider the interdisciplinary team beyond what we traditionally consider to be medical, nursing, allied health and pharmacy, for example, but drawing on expertise within the organisation that provides a more holistic lens of the data that's available for the analysis. So that's where calling on the health information managers because of their coding expertise, and also the health informaticians that are within our performance units. Using the triangulation and the deep dive into the data, combined with the important conversations and analysis from clinicians on how they're delivering care, goes a long way in identifying what are the contributing factors to variance in clinical practice, and what are those contributing factors that can be improved to help minimise unwarranted variation. Documentation, audits, observational practices, all of the observation of practice are all important data sources or information sources to help create that picture of where we need to improve. This slide is information dense, but I really just wanted to illustrate the coming together and the interdisciplinary analysis occurs in lots of different ways. We've got risk-based committees, so where there are identification of clinical risks, they are aligned to those established committees and they have the clinical leadership around the table to inform where we need to improve. We have an evidence-based review committee, and the committee is probably not quite the accurate term. It's probably more of a council in that it's not decision-making, but it provides the organisation with recommendations based on the evaluation of best practice and ensuring that practice is consistent and cost-effective. It's really underpinning those appropriateness effective domains of quality that committee oversees. The other element is around topic-specific working groups or task forces, and these arise in response to emerging risks or in response to the coming together of people that are enthusiastic, curious and have energy about understanding the appropriateness of the effectiveness of the care that's delivered within their domain. So here I've given the example of our hospital-acquired complication working group. Others, for example, in more recent times, there was the sternal wound infection task force. So again, bringing senior clinicians together with the right people around the table to be able to accurately understand the clinical workflows that are leading to the patient outcomes and identifying opportunities for improvement. I'll step through an example at Alfred Health. This is an actual, whilst it says case study, it's actually an example of where we've identified clinical variation and suboptimal patient outcomes, and where we've had a targeted intervention approach to improve patient care in this space. It relates specifically to hospital-acquired anticoagulant-related complications. In terms of this particular issue in patient care, we knew that we had a problem through our serious adverse event process. And we knew that we had patient mortality where suboptimal anticoagulation therapy had been considered a potential contributing factor to the patient's outcome. It's been identified as a risk on the high risk register, And in review of patient-level data as part of the routine audit against best practice guidelines, it also identified challenges, and in conversations with clinicians, identified the challenges that they were experiencing on a day-to-day basis caring for our complex patient cohort. There's often conflicting indications for prophylaxis management, managing that delicate balance between the risk of bleeding versus the risk of developing an inpatient PE or DVT. It also was flagged, we've also been flagged as an outlier in the health roundtable data around the hospital-acquired complication, VTE, hospital-acquired VTE. So all of these came together and formed a picture that we had an issue, and we needed to have some targeted intervention to understand what the issues were and then address them systematically. So what did we find as part of that analysis? Convened the interdisciplinary group. It revealed lots of useful insights that helped then inform the improvements. Completion of risk assessments on admission wasn't as consistent as the evidence would advise that it should be. Talking with clinicians, it highlighted the challenges that they faced in terms of the complex patient cohort, particularly the surgical patients, and trauma being a significant proportion of those. Documentation of mechanical prophylaxis. So as part of the medical record review, identifying patients that clinically would have been appropriate for mechanical prophylaxis, yet there was no evidence of the consideration for that as an intervention. And then the fourth point, which was perhaps the most interesting, and also it's an important learning, was that there are some cases where patients, despite our best efforts, they developed an unavoidable DVT or PE. And this was due to, again, the complex nature of our patient cohort and the unmodifiable patient factors that contributed to that patient risk profile. But altogether, it provided a roadmap, really, of where we needed to improve, implement strategies to support clinicians, and they're listed here. As you can see, it's a comprehensive program, and it's been underway for quite some time now. As a result of the reviews, a dedicated VTE specialist pharmacist role was established, a carrier pager, the numbers on it spell out clot, and they're a fantastic resource that's at the elbow, at the end of the phone, for clinicians to be able to obtain advice when they're navigating those high-risk patient groups, and the surgical group, as I said, in particular. The governance has been established. There's a well-established anticoagulation stewardship committee. It's modelled on the antimicrobial stewardship approach. And again, senior clinicians around the table have very clear remit in the oversight of the safety and quality of care delivery within this particular domain. We had opportunities with the implementation of the electronic medical record, which was rolled out a couple of years ago. As part of that design and implementation, there was the opportunity to build in evidence-based practice and guidelines that to support clinicians at the time in terms of clinical care delivery. This occurs in the form of risk alerts. So there are alerts that trigger and prompt clinicians to complete VTE risk assessment, and also to then guide them in appropriate care management. And then lastly, there's been intensive effort working with the clinical units, targeting those high-risk patient groups and tailoring the evidence-based practice guidelines to better meet their unique care needs. So has it made a difference? And the answer is yes. So you can see over the last 4 odd years, we've managed to achieve around about a 66% reduction in the rate of hospital-acquired PEs and DVTs. So it's fantastic. It's certainly, we're kicking goals. You can see from this slide that in terms of the risk profile of medical versus surgical patients, you can see that the surgical patients continue to be our high-risk group, but they also are heading in the right direction in terms of the occurrence of hospital-acquired PEs and DVTs. But the challenge is, do you think we're there? Have we solved it? Have we arrived at our destination? And the answer is no. It is absolutely a journey. We're continuing to do a deeper dive with our health roundtable data to better understand the contributing factors to our outlier status, with early indications with thinking that it's the trauma cohort that are contributing to that. It remains on our organisational risk register, and just recently we've identified a couple of key metrics to elevate it to the executive or organisational quality and safety performance report so that it has that high level view and profile in terms of this being a particular risk for us. And then of course continuing to work with the high risk groups, for example burns patients. We provide a statewide service for burns, and working with that particular group in again tailoring the evidence-based guidelines to better support those patients. So in summary, a systematic review of clinical variation is an iterative journey, and it needs to be underpinned by strong clinical engagement as well as data-led continuous improvement. Embedding and integrating the approach with the clinical governance framework of your given health service will provide a solid foundation for enduring oversight of the appropriateness and effectiveness of healthcare delivery and patient outcomes. Regardless of where you are on your journey, make sure that you stop, you pause to celebrate your wins and successes in improving patient care and sharing your learnings along the way. For Alfred Health, this takes the form of a Chair of a Board Award for Patient Safety and Quality Improvement. We've got a couple of examples of last year's winners there on the screen for you. It also takes the form of share and showcase events for our clinical programs, providing them opportunity again to identify where they've to share where they've identified opportunities for improvement in the clinical care delivery and the achievement of improvements in patient care experience and outcomes. For our clinical units, they provide an annual report presenting their quality and safety performance over the year and highlighting any key improvements that they've undertaken and outcomes that they have achieved in terms of progressing, improving patient care. The annual audits consist of, there is a requirement that it consists of benchmark data. So there certainly is the maturity in terms of that analysis of performance and the identification and proactive management of unwanted variation. This concludes my journey with you to the Hitchhiker's Guide of Clinical Variation, and I thank you for your time. I'll leave you with the wise, friendly words of Douglas Adams, and that is, don't panic. And I wish you all the very best on your own journey through the review of clinical variation and improving patient care and outcomes. Thank you.
Hi, I'm presenting a case study in driving change from our experience with the Australian Stroke Clinical Registry. A little bit about us. I'm Professor Dominique Cadilhac from the Florey Institute, and I'm the data custodian of the Australian Stroke Clinical Registry, and I'll be presenting this session with Nicola Hall from Logan Hospital. I'm going to start by just giving a bit of highlights of stroke care in Australia. One person has a stroke every 19 minutes in Australia, and it is a leading cause of death and disability. It was estimated in 2020 that over 450,000 people were living with stroke, and 1 in 4 of these are under 55 years of age. We have effective treatments that we can provide people with stroke to make sure we can reduce their chance of having disability or dying after stroke. However, there are challenges in implementing these evidence-based treatments, and not all hospitals perform the same. So I'm going to talk about the way in which stroke care and continuous quality improvement work hand in hand to ensure best practice management within Australia and ensure that where there are issues or gaps in practice that we can address those directly. First, we have evidence-based clinical guidelines that provide the recommendations for treatment. We also have frameworks for standards of care that we expect in the hospitals to be offered, as well as care standards by the Australian Commission on Safety and Quality in Health Care. We have ways of reliably collecting data through our Australian Stroke Clinical Registry and performing analyses so that we know we're comparing like with like. These data can then be used for quality improvement activities, and Nicola's going to talk about a case study from her hospital. What this then leads to, this virtuous circle of guidelines, data collection, quality improvement activities, is improved care and better patient outcomes after stroke. So how do we use data to drive improvements in hospital? One of the big concerns is that, firstly, people are aware when they have stroke symptoms that they need to get to hospital quickly. Around 1 in 3 are coming to hospital within the window for thrombolysis, which is around 4.5 hours. The other issue is that we're not really seeing shifts in the delivery of intravenous thrombolysis to our patients. And this is a clot-busting drug that, if given early, can really reduce the effects on immobility, unable to speak, or having other problems after stroke. And what's a real concern is that we lag behind other countries in the delivery of this treatment. When people get to hospital, we're very slow at delivering it. We don't achieve treatment within 60 minutes of hospital arrival as often as our colleagues. So what is it that we can do to improve aspects of care like intravenous thrombolysis? So we established the Stroke Clinical Registry in 2008, and it follows best practice standards, including opt-out approach and a waiver of consent for people who die in hospital. This means that we have as much information on all patients and we avoid selection bias. We have an agreed national minimum data set of priority indicators, and we collect these on all consecutive admissions rather than snapshot audits of medical records, which have their place as well. But having consecutive data on a minimum data set really means that we can track well some of the priority measures that we want to deliver in Australia. The other thing that we do is we collect patient follow-up surveys, whether their quality of life has been impacted, whether they're still living at home, whether they've had to go back to hospital. And we also link our data to the national death records so that we understand survival relationships as well. How are we going with the registry? Well, at the moment, we have 86 hospitals approved to collect data. We have to go through an ethics approval process. And we have over 112,000 episodes of care recorded in this system, mainly from hospitals on the eastern seaboard. And we have followed up over 50,000 people who are living in the community with stroke. We now use the data to inform what happens in usual care. So we know that around 8% of people die in hospital, 1 in 4 will go to inpatient rehabilitation. And when we collect our data of people living in the community, about 1 in 4 are free of disability. However, 1 in 2 report problems with mobility, pain, anxiety and depression. Access to stroke units is very good in our sample of hospitals, but there are differences depending on access to thrombolysis, depending on where you live. But does it make a difference? Do delivering these bundles of evidence-based therapies work? Well, it does. This graph highlights the dose-response relationship if you're to get none, 1, 2, or 3 quality of care indicators. And if you get all of them compared to none, you have a 70% reduced hazard of death and an 18-point increase in the quality of life. This is massive. So how do we use the data to drive quality improvement? We use it through the Plan, Do, Study, Act methodology, plus external facilitation that is supported by the work we do in collaboration with Monash University and the Stroke Foundation. And we help sites to agree on action plans to address areas where they're underperforming. We illustrate areas of underperformance through these data feedback graphs where we highlight a particular hospital against the performance of other sites, which is designated by each of those bars. And then we also highlight what the achievable benchmark is from the hospitals that provide best practice care most of the time. In the state of Queensland, we were able to use and look at the impact of financial incentives and facilitators to help with that quality improvement practice cycles. What we found was, although financial incentives created the largest shift in practice for accessing improvements to stroke unit care, providing the Enhanced Stroke Link program as part of it with the external facilitation where hospitals were provided support to create action plans and address practice issues, still led to an overall change of 18%. I'm now going to hand over to Nicola Hall from Logan Hospital in Queensland to present a case study of how this type of activity works. Thank you.
Thank you very much for that background and introduction, Dominique. As you mentioned, I'm going to be presenting a case study from Logan Hospital and how we've used the information that we've gathered in the Australian Stroke Clinical Registry. So following the guidelines for reducing variation in care as well, we selected a priority area for assessing and reporting this variation. And we became aware through some of those processes that Dominique mentioned of a less than optimal blood pressure lowering medication prescriptions on discharge. And this is just one aspect of the secondary prevention that's really important for patients. We know that when patients are put on these medications when they're discharged from hospital, they have a better chance of continuing to take them and therefore a better chance of reducing their rates of having a subsequent stroke. So we identified how that clinical variation would be assessed. We had data pertaining to our blood pressure lowering medications through the Australian Stroke Clinical Registry. And we saw these things being presented to us at forums. So the actual process of care certainly aligns with a minimum standard of minimising stroke secondary prevention. And so we went on to really dig down and measure how this variation was and review our performance. We did this both internally and externally. So those external processes came from the Australian Stroke Clinical Registry reports, presentations at our stroke forums. And from that, we were able to actually dig down into the specific patients. We were able to identify which medical treating teams were caring for them and where the variations were. So this was just all these graphs represent part of the picture. And then, as I said, there was a really in-depth analysis. So we went through that and we explored the reasons for that variation. And it was really interesting. We identified that the process provided us an opportunity to support the data collection, and I was very involved in that data collection, and I realised that there are opportunities to not be quite so purist about things. And one of the things that was identified that while we were saying no, a patient wasn't being discharged on these medications, in actual fact, there was a contraindication for it. They either had a low blood pressure or there was some other indication that it meant they shouldn't be. What this highlighted for us was our documentation wasn't really reflecting that. So we did a lot of work on working with the clinicians who document to improve that documentation so that then we could identify who were had contraindications. The data was really, as I said, broken down right to the treating team level. So then we need to do that feedback. So our processes to improve that care and embed those changes, they included the data being presented to the medical consultant teams in a de-identified way collectively. And the interesting thing was most of them wanted to definitely engage one-on-one. It gave the medical teams who were following the processes really well the opportunity to celebrate that. And it also gave us the opportunity to work with the teams that probably weren't quite as diligent, and not so much with their processes of care, but particularly with their documentation. So all of that improved. We've had provide ongoing support for our medical teams, and as the clinical nurse consultant for stroke, I send out a welcome email with every rotation to registrars and residents, introduce myself as an ongoing resource for them, and also just highlight the specific aspects of care that are particular to stroke, and strongly recommend that they access the national guidelines. And as I said, am available for their ongoing support. So we continue to report those activities and monitor that variation. And I'm very pleased to say that we utilise our quality improvement activity registrars. We have a dashboard, and we present to our stroke steering committee. We have good governance in the hospital, and the findings and outcomes are shared to the whole hospital organisation through medical grand rounds. And that's only one aspect of the processes of care that we've analysed. We've analysed a lot, and obviously we only had time to present one case study. So I hope that was informative for you, and if you need any more information, please contact the Australian Stroke Clinical Registry. Thank you.
Hello, I'm Jackie Close. I'm an orthogeriatrician in Sydney, and I'm a co-chair of the Australian-New Zealand Hip Fracture Registry. I'm going to be talking to you today about clinical variation in hip fracture care, and how the Hip Fracture Registry has been a vehicle both to identifying variation in practice and, importantly, driving change. So the first step is really to select a priority area. So why select hip fracture for assessing and reporting variation? Well, hip fracture is high volume. There are over 20,000 hip fractures in Australia every year. It's high cost. It's high cost to the health system, and perhaps more importantly, high cost to the individual in terms of loss of function and loss of independence. We have evidence-based guidelines that actually direct care, and we also know that if we follow evidence-based guidelines, we deliver better outcomes for older people. And what's more, we also know when we deliver better care that it actually costs less. In terms of building our case for change, so this was a paper we published in 2014, and it specifically is looking at variation, this time in adjusted 30-day mortality. It's New South Wales data, and it highlights variation in 30-day mortality across the different hospitals delivering hip fracture care. So the yellow diamonds are hospitals that have an orthogeriatric service. The black diamonds are hospitals that don't have an orthogeriatric service, and the orange circles are our major trauma centres. And what this slide shows is that you are significantly less likely to be dead at 30 days if you're cared for in a hospital that has an orthogeriatric service. We also know from the UK, who are ahead of us in terms of registry data, they were looking at, this is an external evaluation of the registry, and even before the introduction of the registry, so this again 30-day adjusted 30-day mortality, we can see that hip fracture 30-day mortality was already coming down before the introduction of the Hip Fracture Registry in the UK. But what you do see after the introduction is a more precipitous reduction in 30-day mortality. And the BMJ produced a paper suggesting that the introduction of the registry in the UK has probably saved as many as 1,000 lives. So step two, how we identify clinical variation, how we will assess it. So for the Hip Fracture Registry, it has been our triad of NHMRC endorsed guidelines which tell us what the evidence says in terms of how we should be delivering care. Our 2016 clinical care standard produced by the Commission, which provides us with 7 clinical standards with clinical indicators, which are then reported in the hip fracture registry. So to show you how it all comes together, we have the guideline, which tells us, as one example, perform surgery on the day of or day after presentation to hospital with a hip fracture. The clinical care standard tells us to operate on people within 48 hours unless there's a contraindication. The indicator that is partnered with the standard is the proportion of patients receiving surgery within 48 hours, and that data is collected and reported in the registry. So you can see how it's all brought together. So I'm going to give you some examples of how we share that data across Australia. So here's time to surgery. We have the hospitals listed down here. You won't be able to see the names, but the names are actually reported. But I'm showing you here significant variation across the hospitals in Australia in terms of time to surgery. So we have the top performing hospitals up here. We've got Royal North Shore, Charles Gardner, Rockhampton, Fiona Stanley, St Vincent's and Darlinghurst. They're all managing to get people to surgery within 24 hours. Meanwhile, we have a number of hospitals down here who are struggling to get people to hospital within 48 hours. It's also important to start looking as to why those delays are happening. And in the 2020 report, we can see that the most commonly reported cause for delay is actually access to theatres. We've still got issues with clearing people medically and anticoagulation, but there's an indicator here that tells us we need to be doing more around access to theatres for this population. We can track change at a number of different levels. So this is Australia-wide data. I'm showing you nerve blocks before surgery, so form of pain relief. And in 2015, we'll see that people got nerve blocks in the emergency department and the operating theatre, or just the emergency department, 30%, just over 30%. That percentage has increased quite dramatically. And in the last report, 77% of patients coming through our emergency departments with a hip fracture are getting a nerve block prior to surgery. So that's a significant improvement in performance, thanks a lot to work through the emergency department and anaesthetics. We can also track change at a hospital level. I can only show you Prince of Wales data because that's where I work. We've been entering data from the very beginning of the registry. And at the very beginning of the journey for us, our average time to surgery was about 44 hours. You can see here, over time, our performance has improved, and we're now sitting around 24 hours. And that's a concerted, focused effort, predominantly through theatres and orthopaedics, securing access to theatres for our patients. We're also able, with this report, to compare our performance with Australia, which is the continuous blue line, and New South Wales with the dotted line. Of course, the report, when we publish it, is actually out of date. And what the exciting part of the registry now is the ability to look at your data live. So I'm doing this presentation on the 9th of December. You can see that the entry for Prince of Wales was on the 8th of December. So this is up-to-date data. We've had 158 records in 2020. And this right-hand panel here tells us how we are performing in terms of our times in the emergency department. They're not good enough. Here's our median time to surgery as of yesterday, our acute and our total length of stay. And importantly, for accreditation against the national standards, the live dashboard actually provides you with up-to-date data on how we are performing against the quality standards. So for Prince of Wales, 94% of our patients this year are having surgery within 48 hours. And we know that's an improvement from our performance last year. So step 4, so it's okay identifying clinical variation, but you need to do something with that information. So for the hip fracture registry, we use that data really to start conversations, and we've had a series of hip festivals across all states in 2019. COVID-19 put pay to the HIP festivals for 2020, but we hope to resume them again in 2021. And really, these are people coming together to share their learnings, their successes, and their failures. And it is important to learn from the high performers. So this is a picture of the team at Fiona Stanley Hospital, so one of the top performers in terms of time to surgery. This is their 7:30 trauma meeting that they have every weekday morning, where the anaesthetists, the surgeons, and the geriatricians sit down together and plan the day. Who's going first, who still needs to be reviewed, and they run like a well-oiled machine. So lots for all of us to learn from those top performing hospitals. The reality is a lot of clinicians are inherently competitive. So we are in a bit of a competition through the leading better value care work in New South Wales. So Prince of Wales, Liverpool, St George and Sutherland are competing to improve their time to surgery. But the overall goal of this particular project is that by the end of 2020, all 4 hospitals combined, over 85% of patients will receive surgery within 48 hours, and we are on track to achieve that. And in terms of rewarding practice, at the end of each quarter, the top performing hospital is given a $500 voucher to spend on whatever they want. It's a small amount of money, but it's recognising good practice. So the sorts of things that have been purchased, this is a pocket talker, which helps communicating with people who are very hard of hearing. This is a speaker that one of the hospitals wanted, so to be able to play music in their hip fracture theatre. It's also, of course, important to be aware of the onus and the work that it takes to collect this data. So it is important to try and maximise how we use data through data linkage. So this year is the first time we've reported adjusted 30-day mortality, and we do that by linking to the National Death Index. And what you can see here with this caterpillar plot, again, is substantial variation in 30-day mortality across the hospitals. Now, we haven't named hospitals this year. Hospitals will get the option of whether they want to be named in next year's report. But overall, our 30-day mortality is 7.1%. That compares very favourably with the equivalent work from the UK. But there is very definitely a difference in mortality, even when you adjust for baseline differences. Also important to use the data to drive change. And here's an example of how that's been done. This is James Brinton. He was a senior nurse down in Illawarra Shoalhaven. He was responsible for some of the work at the Wollongong Hospital, and the Wollongong Hospital was unfortunate enough to find itself at the bottom of the table in terms of time to surgery for hip fracture. And this is for the 2017 report, and they were struggling even to get 50% of patients to hospital within 48 hours. They did a concerted piece of work through the emergency department, surgery, theatres, etc. And this is where Wollongong Hospital sits in the 2020 report. So evidence that they've owned the data, done something with it, and as a result, we see improvements in practice. In terms of reporting and recording activities, we continue to report on an annual basis for the hip fracture registry, but as I said, the live dashboards are becoming increasingly important when you're using data to drive a quality improvement agenda, and certainly that live dashboard sits very nicely with being able to report for the Clinicians standards for hospitals. So what next for the registry? Well, we're still fairly acute focused. What we really want to know is whether our systems and processes of care are actually delivering better outcomes that are meaningful for patients. So we are collecting data at 120 days, including quality of life data. We're giving serious consideration to having a public-facing dashboard that tells the public how we're performing as a country and as individual hospitals against the clinical care standards. We're looking at developing apps which make it much easier to look at performance over time when you're sitting down with a manager to have a conversation, being able to bring up that live dashboard at the push of a button. We are certainly going to be using data linkage to try and collect more information, so links to the pharmaceutical benefits scheme, to the aged care data, to see what's happening to people further down the track and whether we're managing to get people on treatment for osteoporosis, as an example. We're aware of the encumbrance of data collection and we want to avoid duplication of data collection, so how we embed the components of the registry into the electronic medical record, that's a conversation that is ongoing. We've had previous conversations about putting a price on quality, and instead of penalising poor practice, how do we change the conversation to actually rewarding high quality care? And I guess ultimately the annual report will become a thing of the past as we move to reporting real-time data. So I hope that gives you a snapshot as to how the registry is identifying variation, and equally important, how it is using that data to start conversations to drive a quality improvement agenda. So I look forward to participating in the discussion. Thank you.
I think you'll agree with me. They were 4 very powerful presentations, a wealth of information. But what really grabbed me was, what's the human benefit of all this? There are clearly thousands of patients who have gone home better off, gone home at all, because of the work that these groups of people have been able to achieve. As Nicole said, it's haven't got there yet, more to be done. So we've got some great questions, but I want to start off by asking each of the speakers who've been dealing very much in registries, and a lot of this change is based on getting good data. And clearly registries have a role to play. Can I ask each of you, where would you like to see registries in 2 to 5 years in terms of supporting clinicians and health systems to really iron out and drive down unwanted variation? I think I'll start with Erwin and work up the screen. How's that? Are you happy to start off, Erwin?
Sure, Anne, and thank you for this time we can have together with all the fellow experts. I think you're raising a very good point here about the utility of registries and where do registries fit in the whole clinical governance framework. Registries traditionally have started off with clinicians sharing data to improve individual performance and to benchmark themselves with one another. But I think they have evolved to become quite sophisticated quality assurance databases and also a tool for research. I think, as you say, it's how we ensure that registries go beyond just being individual cottage industry type tools to being used on a regular basis as part of a suite of data indicators that hospitals can use to help them improve their care to the patients. We do have a way to go because at this point, hospitals in general find it hard to integrate registries into the scorecards or the suite of KPIs that they do monitor and report on, and then escalate to the executives and to the board. But I do think that they do have, as long as someone put into the public chat, as long as it's timely, that they have sufficient information for hospitals and health services to action, I think then they can be very powerful and triangulation data for hospitals to use to improve their care. I hope that kind of helps.
Yeah, it does. I think so. Anyone else want to make a comment in that regard? Because I know you're passionate, Jacqueline, and I know, Nicole, you've got 70 registries to monitor. And also, so anyone else like to comment in that regard?
Very happy to comment, Anne. There's been a real proliferation of registries, perhaps in the last 5 to 10 years. So one of the things I'd really like to see is a consistent approach to the quality of the registries, good governance structures, and the ethics processes for hosting registries also sorted out so that we don't have 6 different states all having 6 different processes. The idea that the registries should be real-time, that's a true ambition, because if you're seriously using registries for quality improvement activity, you really do need to have your data real-time. The reports that come out 9 months after the end of the calendar year are of limited use for that. And the other thing we really need to think about and remember is that the impost on clinicians of collecting the data. So where possible, we should be trying to embed our variables in existing electronic systems. That may not always be possible, but where we can, we should be doing it. And the other thing, of course, is a lot of registries are very acute focused, and what we're not good at doing in health is actually following people up longer term and thinking about outcomes that are more important to the human being rather than the health system. So being able to have effective data linkage that allows you to track people over time without the additional impost of having to collect data. So that's a number of things that I think we should be focusing on over the next 2 to 5 years.
Thank you. Nicola, you represent the non-academic centre, the real world of trying to, a smaller place, I don't know the size of Logan, but across Australia there are small health services that are trying to do their best, and collecting data is a little bit harder when you've got fewer people on the ground. Any comments on how smaller institutions can be supported, or how you got to where you've got to?
Thank you. Definitely the Australian Stroke Clinical Registry do offer terrific support for smaller facilities. And there's a Queensland project officer who will go out. A couple of the team just last week went out to Emerald and supported the team out there with looking at their processes of care and how the stroke registry can be utilised. So we got to where we are, I think, through definite acknowledgement of the advantage of participating in the registry, and also that consistency. So having the quality processes just going around the circle. And just to pick up on one of Professor Lowe's comments about feeding back to the executive team, just recently the Stroke Registry provided CEO reports in Queensland. So they went up, they showed how each facility was performing and also a bit of comparison with their peers. So it really is about engaging with the whole team, and those smaller facilities that want to participate, there is definitely support available.
That's fantastic. I think it's fantastic. In Australia, we have a strategy around registries, because quite clearly what everyone has said is data really drives change. I want to just move direction slightly, because one of the really important questions people time and again ask is, how do you engage up and how do you engage down? So how do you engage boards and senior executives in this? Does anyone want to reflect on their experience?
It's Professor Dominique Cadilhac, the data custodian for the Stroke Registry, and I'm happy to talk to our experience. And what we have had to do is work very closely with the state governments that fund our registry in each state, and ensure that the information that we provide back to clinicians is appropriately packaged for them. But then we also work with our health department colleagues and clinical networks to feed back that information in board reports. So we have 2 indicators now in the Victorian board reports that come through the registry at least twice a year. And we also issue a CEO report. So that information is refined down to the main important messages that we want to get through at that level. And we haven't, it's sort of more of a one-way direction, because we're not sure exactly how CEOs are using that information. So I think that's another way in which we need to think about how registries can work more closely with policy partners and hospital executives in unpacking the meaning of the data and then following up to know how that information's been used at the different levels. Because we're very good at engaging with our clinical participants that are working with us with the registry, as Nicola has highlighted. But sometimes it feels like you're sending information into a vacuum. So where we've set up committees with government where they're, actively looking at the data, reviewing it, thinking about where they may want to do some peer support in terms of areas of underperformance or priority setting. We found that that's really helpful because we can see the data are being used. But at that upper level, it kind of, we know they're getting the information. It's just what weight they're putting on it in relation to everything else that they have to absorb.
I was thinking about that aspect of everything else they have to absorb. So I'm thinking about Alfred Health must have an enormous number of things that the senior execs and the board is dealing with, likewise for St Vincent's Health. Nicole, can you give us a bit of background? Because it's really important for people to be able to be persuasive and get support for their projects.
Thank you. Yes, it can be challenging, and I think with the executive and board, their view is strategic, and there's we're drowning in data and information, and being able to distill that in a meaningful way for the executive and board to then have a sense of where there needs to be priority, focus, and action. I think for us, we've established processes like a monthly clinical governance report, which is risk-based and distilling it down in terms of a monthly performance on end. However, there is also data that's presented with trends over time, so it's getting a sense of progress towards the strategic goals and key priorities. I think it's really important it's important obviously to be data-led, but to also include the consumer voice and patient stories, and it's patient experience and outcomes that kind of put the flesh on the bones of the data, and that then can help shape where action needs to be galvanised. I think that for us, we've got the integrated risk management approach is really important in being able to focus effort. We've got, so for each of our clinical risks or risks on the Enterprise Risk Register, it has a corresponding executive owner. Our patient safety related committees at an organisational level are chaired by executive that align with risks where it's relevant. As far as the board goes, we've got each of the medical units need to undertake an annual audit presentation that gives an overview of their service delivery of the preceding 12 months, and also provide an overview of quality and safety performance and comparison against peers. Those clinical audits, the heads of unit are also invited to present to board their annual audits, and it's a really important way of engaging the board and really bringing, I guess, board members to the bedside, I guess, for want of a better expression. And then the other important element of that, particularly I think for executive and board, is engaging them in and sharing the improvements and the wins along the way. We tend to focus on where the gaps are and where we need to be striving to improve, as opposed to pausing in for a moment in time to actually celebrate where we are making progress, and particularly in areas of that have been challenging as far as patient experience and outcomes. We have an annual chair of the board for Patient Safety and Quality Improvement Award, and that's presented by Michael Gorton to the recipients of the award, and it's a really good opportunity for senior clinicians to meet the board and to engage in those conversations about quality and safety and improvements and challenges, obviously. So I think they're probably the main points I'd make.
Fantastic, thank you. Erwin, did you want to add anything from that broad perspective? Because I think then we'll ask Jackie, how do you get, as a clinician, one up there? But over to you, Erwin, then Jackie.
Yeah, so I think managing up, to be frank, for a lot of us in senior health executive positions, that's our main job, is to ensure that, one of our major jobs is to ensure that the board and the rest of the executive are across what's going on in the health service. And I think from my point of view, there are three principles, and they relate also to this discussion around registry data and clinical quality data in general. I think the three principles are, number one, it's providing the facts in a timely and accurate manner. So the data itself, as we've discussed, has to be the right data. So we need to present the right data to them, format it in the right way, as people are saying, so they understand, because they get so much information as it is. The second principle is no surprises. So this is about the fact that no one likes to be surprises. And I think I've experienced where, the executive team have been blindsided because a board member has looked up a website to see the adverse report of a registry in relation to the hospital that they were at, when we didn't know about it. So somehow the report went to the clinicians, but never actually came up to the board, to the executive level, and then it went straight to the board because they found out from another source. So you want to make sure that that channel of communication exists with the executive, and it sounds as though the more mature registries are doing that in a very good way. And the last thing I think, which is another principle of managing up, is if you find out that there is a problem, you need to also present the solution. So again, I referred to it in one of my answers. The more mature registries like VASM or QASM or the stroke registry would look at the variation and then come up with some solutions, come up with some recommendations, and share the learnings from organizations that are doing well, so that you can then, as you report on any deficiencies that you might have from the registry, you also report the solutions, you report the actions that you're taking. So from my point of view, managing up is key, but that's, as Nicole is saying, that's also about engaging the board and the leadership and the wider organization.
Solutions focused, absolutely. Jacqueline, you've been very dynamic in the world of hip fracture, and the hip fracture registry's come a long way. How have you been able to engage back at Prince of Wales, your exec, to get support? Or did you want to make a comment? Now, Jacqueline, you're not, I can't hear you.
I guess my answer is not specific to the Prince of Wales. It's a more general.
Okay, great.
I think the game changer for the hip fracture registry, which is still a very new registry, is actually publishing results with hospitals named. So suddenly everybody sits up and takes notice, because nobody wants to be the one with the lowest rates of nerve blocks, or the slowest time to surgery, or the shortest length or longest length of stay, etc. So I think that for the registry has been a game changer, and it has enabled clinical teams who perhaps have been frustrated about accessing theatres or getting X, Y, Z in place, being able to go to the senior executives and saying, this is our issue, this is what we think might be the solution, can you work with us? So I think that's been a real game changer for us. And I guess, and the other thing I would say is, I know you're talking about reporting up. For me, I think probably the most important thing for registries is reporting to the public, to the people that we are meant to be serving. And actually, a lot of the patient stories that you get from registry data, they're as important to hear as the actual quality improvement type activities. And we're not good enough at the moment in terms of reporting effectively to the public. And when you look at the way governments make decisions, a lot of them are influenced by stories from the public rather than clinicians sending in run charts or whatever. So I think we need to be smart and engage both in terms of the senior exec and the board, but also bear in mind that this is information about the public that we are there to serve. We need to be able to provide them with the information as well, and they can digest and use that information in whichever way they see fit, but it potentially can work to our benefit.
Certainly a very important point. Standard 2 is about partnering with consumers. I'm sure many of you have spent hours thinking about this and have iteratively got better and better. Does anyone want to make a comment on what they've been doing or what they see is a way forward, or some of the challenges they've faced and overcome in relation to engaging consumers? Because quite clearly you've demonstrated data that if I were a potential patient going into your facility or system, I'd be really very pleased to know how the performance is.
It's Dominique. I'm happy to explain some of the things we do to engage our consumers. So firstly, we have a member, a consumer representative on our steering committee and management committee. Mainly on the steering committee, and on the committee that looks at the infrastructure, the technology platform. So we have a consumer representative on each of those committees. So they provide input and help us review our different, like our patient information sheets and different policies and procedures that we're putting through to make sure they make sense. The other thing that we do is each year when we produce our annual report, we write a public summary. And we did a piece of research on that a few years ago where we brought people from our registry who had agreed to participate in future research activities to come and review that and feedback the best ways of presenting information so that they could understand it. So we have subsequently produced that each year. So they're two of the things that we do that are really important. The other thing is that we look at how we co-design different approaches to whether it's feedback reports to end users such as the clinicians, and we involve consumer representatives in that as well. So we've just done a large piece of work with the Victorian Agency of Health Information on how to feedback patient-reported outcomes such as quality of life back to clinicians in terms of how to judge performance and how to understand the graphs and the best visual displays and the sorts of information they need to understand the data. So that goes to one of the questions Naomi Poole asked about what training and things. So I think there's important lessons for the whole, whenever you engage in any activity to improve a process or set up your registry, that you are involving consumers, whether that's the clinical sphere that are going to use the information that you're providing, as well as for the public and the people living with that condition. And we're very fortunate that we've had that question built in since the beginning, and we have, 64% of respondents say they want to be contacted for further research, which means that we have a registry of stroke survivors within a registry that can help us either resurvey them on issues that they're having in the longer term after stroke. We've conducted various other projects, but importantly, when we're trying to redesign aspects of the registry and get their input, we can reach out to them.
Thanks. Does anyone else want to comment? Erwin, is that a yes and a nod?
No, I was just nodding, but I think, engaging them, I think Dominic touched on consumer representation and engaging them. And I think part of the challenge of organizations is engaging the right level of consumer and making sure that they are supported, making sure that they receive appropriate remuneration and training, and that they're not alone. So usually you have two. And, that talks to health literacy and how we pick our consumers, and also the diversity of backgrounds, because as we know, our community is now quite diverse, and our consumers need to represent the community as well. But the other side of it is, and we touched on it, is, and Jacqueline very eloquently talked about public reporting and how registries need to be public, but it's how we continue on our journey to be more transparent with our community as health organizations. I'm always supportive of being as transparent as possible. There should be nothing to hide, and it's how health services mature in that journey to be open. I know the Commission's doing a lot of work on this. I know some of the committees looking at it, and I think over time consumers will be a lot more educated in assessing this, because there's always the fear that they will be biased, they'll jump to conclusions. But I think consumers already, all of us are consumers, and we already have lots of data around all sorts of organizations out there. We look at and we are most people are clever enough to understand the nuances that are involved. And I think as we share more data at the organization level, and then we move down to the holy grail of individual clinician level data, then I think we empower everybody as a society. I think we get much better care over time.
Good point. Good point. Anyone else want to comment?
I think I'd just like to, thank you. I agree with Erwin in that it's having the support available for consumers, and particularly in their involvement in governance groups and improvement groups or task forces, as we tend to refer them. It's being able that they do what, they're in pairs together so that they've got each other, but also making sure that we've got the resources and the personnel to support them to be able to work with the information that we take for granted that people understand, but that sometimes the data can be incredibly complex and confusing, and creating space and opportunity to be able to work with someone to help them understand and answer questions. I think the other thing is working with consumers, that it is at that governance or front end, and we are certainly improving and engaging them in reviews and opportunities like patient information and survey co-design. But I think there's also opportunity involving them in the design of improvements and identifying where the interventions or opportunities for improvement actually lie. We tend to, I think, probably take a little bit of license with that, and it's not until we've determined what the initiative will be, and then we invite consumers to participate in its implementation, as opposed to further back upstream and having that input in those early stages of solution, identification.
Yeah, they're very, very good points, and I think you've triggered early processes.
I was just going to add another point that was also raised in the public chat, but also by one of the other speakers as well. Is it's very easy when we look at data, when we look at registries, to lose sight, and people have referred to this, to lose sight of the fact that behind every single number is a person, it's a family, it's an actual individual. And so at St. Vincent's, because we do have for my organization, St. Vincent's South Australia, it is a complex organization because we have a national board that looks after 36 facilities, hospitals in different states, both public and private. And so for example, do we get our board to get that connection with the front end, the end users, the people that we care for? And so what we've done over the past year, actually, we've started, instead of presenting case studies or reading out incidents, or complaints or compliments, we actually bring patients or the family, or our residents from our facilities to the board meeting, where they present face to face in their own words how we have failed them, and then how we have helped them recover. And that has been very powerful, because that's looking at board members eye to eye, and telling them how we have made an error, but then how we have helped them, how we have recovered their trust, or not, actually, to be honest. Yeah, there have been stories where we haven't recovered the trust, and they've just been very frank. But it's worked very well, because it means that we remind everybody, especially our board members, that behind every statistic is an actual person that we have hurt, and that has helped as well. That is another way that consumers can actually help us change.
Great point. Great point. On our public chat, there's a comment I want to go to, which is a rather interesting one, which is what are the risks and unintended adverse consequences that may result from increased transparency when only some clinical areas, or albeit important ones, make the data publicly available, e.g. focus on prioritising access to theatres for patients with hip fracture may result in other patients not being able to get access within. So how do you juggle that in a sensible way? And then I won't read the rest of the question, but I think you've all had a chance to sort of read it. It's a point that I think is really important and goes to the heart of risk and risk management. So maybe I'll ask Nicole to kick off there, if you wouldn't mind. Have I given you a chance to think about it, Nicole?
If I could have a little bit longer, and I'd like to read it if that's okay, because I think it's a really important question.
We'll leave that for a moment.
Yeah, invite others to comment while I'm...
So it really is that question. And Jackie, you must have felt it from your colleagues saying it's all very well for you. You've now got your hip register, all your patients get to theatre, but us whatevers are now being bumped and our patients are missing out. How do you keep the waters calm and do the best for all patients?
Yeah, it's a really important question Margaret's put up there. But the reality is most of the quality improvement activities that are undertaken in one area of hip fracture care, the reality is they are usually driven by inefficiencies. And when you can improve efficiency in one area, a lot of it actually follows along. So in terms of the issues we've had with access to theatres, where we've had to have a long, hard look at what our issues are, by improving the access for hip fracture through improving efficiency, other fractures and other trauma is also getting in a more timely manner. But it is really important to keep track of that so that you don't see people disadvantaged by one area that just happens to have a nice shiny registry that highlights everything that goes wrong. And the other part of that, so when you're talking about a public facing dashboard, is you don't want to scare the daylights out of the public in terms of showing that, you know, two hospitals side by side, 5 kilometres apart, one of them thrombolyzes 80% of their patients, the other one thrombolyzes 20% of the patients. You don't want the public starting to try and divert ambulances from one hospital to another. But the answer isn't to not highlight it and not have it in the public domain. The answer is to do something about it. And that's my fear is that sometimes if we don't like the data, we are reluctant to put it out there. But actually having a public facing dashboard and engaging with consumers can often help improve efficiencies in the system. But Margaret's point is spot on, and we need to be very careful.
Follow up to that question, Jackie, in your discussion with the other surgical groups who are fighting for access, has it led to other people thinking, gosh, yes, we need to look at our unwarranted variation? And when you talk about efficiencies, is that part of the efficiencies you're talking about? Those clinical groups getting around the table and discussing their triage approach as a department rather than as individuals and looking at the evidence?
Yeah, absolutely. I mean, in terms of just purely wearing a clinical hat, not a registry hat. Yes. Certainly for care of older people in the surgical setting, the surgeons are very aware of what goes on in the orthogeriatric space. And now what we're starting to see is a proliferation of input, or geriatricians with input in other areas of care of older people in the surgical setting, general surgery, plastic surgery, vascular surgery. So when you can demonstrate the benefits of a service, the surgeons will see it very quickly. And very definitely, certainly where I work and a number of other centres across the country, we are seeing far more engagement and better quality of care for older people in the surgical setting. Now, that's a very narrow window that I'm presenting. It's older people, and that's my area of expertise. But that's just an example of you can demonstrate that you can deliver better outcomes. People cotton on that actually it is translatable to other areas of practice.
Fantastic example of diffusion of understanding of unwarranted variation. Nicole, did you want to comment from a higher level, being responsible for quality much more broadly? And I imagine clinicians are keen to compete, and you've got to get the system to look sensible in the way we approach problems. And your work doesn't.
I think it's often a case of the devil's in the detail, and with data, it's the story that's sitting behind it. It's the definitions. It's often we're caught in a trap of comparing apples and oranges, and then needing to make sense of that. I think where it's a challenge with, and I'm just picking up the point which I've now read, in terms of the risks of the transparency and the unintended consequences when some areas have better access to data than others. It is important that the challenge is that the data systems aren't necessarily as integrated, and 5 years from now it would be great if they were. but in the meantime, what data is available? And even if it is for units that don't have access to the shiny registries and the like, what data is available through audit and administrative data that will create and provide a lens in terms of their quality and safety and performance. I think it's interesting that I see Erwin's made the comment about when a measure becomes a target, it ceases to be a good measurement. And that's really hard because there's a constant tension between wanting a target, what are we trying to achieve, have we hit the required target, versus that continuous improvement and striving for better than yesterday. And I don't have the answer. I think it's a work in progress, as I think I said earlier.
We're coming towards time, and I do note that somebody asked a very good question about whether they could have access to one of your documents, Nicole, but I want to broaden it out to all of you and ask the question, you clearly are the best of the best. We don't want people reinventing the wheel. We want to be standing on the shoulders of giants. How do you think that you can help other facilities do better? And what would be your recommendation to other interested groups who really want to get as good as you are in terms of how they can get there faster? So that's how do you? I mean, it really is a question of sharing ideas and networking, etc. And somebody has talked about the Health Roundtable as a great idea. But I imagine in your journey, you've come across some really good ways and connections. Any thoughts, suggestions, help?
It's Dominique. We have the Clinical Registry Special Interest Group that get together, and we share so much information in this space across all the different facets. So I think that's one really important avenue that I've felt has helped me and my team. Whenever I've got a new data manager or a new national coordinator or state coordinator, I really encourage them to make connections with that group so that we don't reinvent the wheel. No one's got time. Even dealing with the issues of ethics or, different responses to government strategies and things, we've found that as a group, we've been able to provide a collective voice as well and discuss some of that.
Jacqueline, any comments?
Yeah, it's a very good question. From the hip fracture perspective, we're doing work trying to capture the key components of how we've got to where we are now from where we started, and then taking that to the Asia Pacific area. So there are a lot of countries a lot less well off than we are, who are keen on developing hip fracture registries. So it's really developing a toolkit that actually takes people through the steps, provides them with links to mentors who can actually help them with each aspect, so the ethics and governance component of it, or the direct clinical types or clinical pathways. So that ability to share broadly, and I really do mean globally, to try and improve care is really important. So, we're all well and good saying, oh, we've developed a nice registry here, but actually how do we take that to the next level? And so that's what we're doing at the moment with hip fracture, is trying to work with countries less well off than ourselves to support them through the processes and not have them reinvent wheels, providing them with anything that they want that we already have access to.
That's fantastic. And rural areas or regional areas that want to get involved in the hip fracture registry, are there barriers, or is it very much a welcome, all welcome, and all ideas shared?
Well, absolutely all welcome. I think somebody earlier in the conversation asked about how do you support rural sites. So there are a number of rural sites that operate on hip fracture, and we absolutely work with them. But there are a number of sites where patients are admitted to that don't operate, that have to transfer patients, and we have a responsibility to work with those sites to support them. So I'm aware of work in Queensland where there are protocols and pathways specifically for rural hospitals who admit somebody with a hip fracture who ultimately will have to transfer them. But in terms of protocols and pathways for, number one, treating them while they're there, and expediting a safe and effective transfer to the operating hospital. And equally, there are very good pathways over in WA. Fiona Stanley takes about 15-20% of its patients from other hospitals. They work with the other transferring hospitals, helping them with protocols and pathways to expedite a safe and effective transfer. So yeah, absolutely, we're one big system. We need to remember that.
Nicola, as a CNC at Logan, do your fellow CNCs have any, what would their advice be to people trying to do it outside metropolitan areas? Any thoughts? You just pick up the phone and ask questions?
Yeah, so just quickly through the Queensland Clinical Network for Stroke Care, certainly there's probably some key CNCs for stroke, and we always reach out. We're available either within our own HHSs or across HHSs, and are always there for a support for those other sites. So very strong network, very committed to helping wherever we can.
And I imagine Erwin and Nicole, likewise, you're happy to help. And of course, you may think this was a Dorothy Dixer, but I just want to advertise it with the user guide. We plan to ask people to write some more case examples so that people can actually work out how to do it in their area. But I think we need to close, and I just want to emphasise to everybody online that these presentations are available to you and your colleagues on our website tomorrow. I'm sure that our speakers would be very happy for you to take each of their talks and present it to the relevant clinical groups or to your boards or to your senior exec, advertise widely, get the message across, and I think it'll help your cause to improve and reduce unwarranted variation. But it leaves me now to thank all the speakers today for their fantastic presentations and discussion, to thank all the participants who've come online and offered questions. If your question hasn't been answered, I'll assure you that we will get to your questions and send it and get you back an answer. I want to also thank our advisory group, of which Erwin is a very active member, and the people here at the Commission who have actually helped get this to where we are today and allowed us to have such a fantastic session today. CPD is an important thing for all of us. If you'd like a certificate for CPD, then just email us at atlas@safetyanquality.gov.au, and we'll happily send you a CPD certificate. And I just want to say thank you, everyone, and I hope it's been a worthwhile activity. I certainly learned a lot, and I'm still reflecting on the number of people who have benefited because of the improvements that have been made, not only where you are from, but where all our participants are from, and the work as a product of the work they do. So thank you, everybody, for joining us today.